Welcome you to this highly anticipated event on the GI360, an extensive assessment of the gastrointestinal microbiome. My name is Joshua Kroll. I am the Sales and Marketing Director for Evexia Diagnostics. I'll be your host for today's webinar, along with my colleague, Dr. Wayne Sodano, the Director of Clinical Support and Education at Evexia Diagnostics. We're joined by two very special guests from Doctor's Data, Scientific Support Specialist, Dr. Julia Malkowski, and the VP of Scientific Support, Dr. David Quig. Dr. Julia will be providing today's presentation, and Dr. Quig will be joining her in the Q&A that will follow. Before we begin the presentation, I would like to provide a brief introduction to our special guests. Dr. Julia Malkowski graduated with a doctorate in naturopathic medicine in December 2017 with advanced standing, and a doctorate in chiropractic medicine in April 2016 from the National University of Health Sciences. Dr. Malkowski has presented at Autism I and the International College of Integrative Medicine 4 training. Dr. Malkowski has completed the Biomedical Treatment for Autism Spectrum Disorders seminar, Fundamentals of Functional Blood Chemistry, Mastering the Thyroid seminar, and 100 hours in functional neurology applied to childhood neurobehavioral disorders. Dr. Quig received his BS and MS degrees in human nutrition from Virginia Tech and a PhD in nutritional biochemistry from the University of Illinois. After a 5-year stint as a research associate studying lipid biochemistry and cardiovascular disease at Cornell University, he was a senior cardiovascular pharmacologist for 7 years. For the past 24 years, Dr. Quig has been the Vice President of Scientific Support for Doctor's Data. He has focused on the influence of the gastrointestinal microbiota on health, toxic elements, methylation and amino acid metabolism, and the applied biochemistry of endogenous detoxification. I will ask that you please type your questions into the chat box on the right-hand side, and we will address them after the presentation. Now, without further ado, Dr. Julia Malkowski.
Hello, I'm Dr. Julia Malkowski with Doctor's Data, and this evening we will be discussing extensive stool testing with regards to the GI360. This is an extensive assessment of the gastrointestinal microbiome. Let's begin. There have been many advances recently with regards to stool testing. Currently, Doctor's Data is bridging this diagnostic gap. In this novel GI360 test, this is the combination of the complementary methodologies, the PCR-based molecular testing, as well as the microbiology, identifying bacteria via their proteomic ID. And so we have these two testing methodologies complementing each other in one test. Therefore, it's extremely comprehensive. The GI360 is able to identify dysbiosis as well as pathogens. The GI360 provides a standardized test to profile the microbiome. Also included is the state-of-the-art stool chemistry analysis and susceptibility testing to guide individualized treatment. Putting all of this together truly provides clinically actionable results, and this is a great thing to add in your clinic. So let's go into the details of this information. Within the GI360, you will see the dysbiosis index, and this is really a test to categorize dysbiosis and normobiosis. So the dysbiosis index test is a focused PCR-based test to identify and characterize dysbiosis. This is a highly standardized, validated, and CE-marked stool test that's used in multiple clinical and research labs. As we can see here, the technical variation with regards to reproducibility and repeatability varies less than 4.5%. That means that across labs, different labs across the world, or within the laboratory across different runs, the results will be the same. So therefore, you know when you receive the results, this is highly reproducible and accurate results for your patients. And that's why this test is used all over in the US and in Scandinavia and all over the world, really. Here's some more information about the dysbiosis index. It's clinically validated. As we said, the dysbiosis index differentiates normal biosis from dysbiosis, and this was involved via studying subjects. So currently, the N is over 1,000 or over 1,100, while this table here has an N of 500. These patients were highly defined via the Rome 3 criteria, scoping to identify the IBD portion of this. And as we can see here, with regards to the dysbiosis index, 74% of patients with IBD had dysbiosis, 73% of patients with IBS had dysbiosis, while 16% of the population had, a healthy, normal biotic gut. And interestingly enough, we do see within healthy people, we do see some extreme dieting and some fad diets that actually do influence the gastrointestinal microbiome to deviate as well. So that's potentially where some of that value is derived from. The dysbiosis index score does go from 1 to 5, and we will see this with the reports. 1 and 2 are healthy, normal biotic guts, and then 3, 4, and 5 are associated with deviations from normal biosis in severity with those numerical values. Here's some information regarding the dysbiosis index in terms of the peer-reviewed journal articles. So there were over 20 peer-reviewed journal articles that were collaborated in the development of this index, including clinical trials, 2 method papers, and this spanned a variety of conditions from IBS to kinetics post fecal microbial transplant. And we're seeing a lot more information about that now, responsiveness of a low FODMAP diet, obesity, all age ranges from pediatrics included as well. So it really is applicable to your clinical setting. Here we see the first page of the GI360 report. What we see here is a web, and this web is a beautiful, simple representation of your patient's results, your patient's microbiome. The graph in the back, that colored area, is the metric of which that's representing your patient's microbiome. So your patient's microbiome is that white shaded area. The perfect result would be along that gray line with the green underneath it in a hexagonal shape, and that would be perfect abundance and diversity with regards to the normal biotic population. And then we can see deviations from normal biosis. So when the web is pulled in, that's a lower deviation from normal biosis, and the web is pulled above there, it is considered, beyond that. And that's the deviation there. So with regards to abundance and diversity, we can see right off the bat here the patient's result. So for this result, the patient is not making a hexagonal shape. So we're thinking that there are some issues with diversity, and also the shape is not, it's pulled in generally, so abundance as well. So this does look like a dysbiotic gut right away. And then we see the dysbiosis index score of 4. Recall 1 and 2 are healthy, normal biotic guts, and then 3, 4, and 5 are associated with dysbiosis deviating from that normal biosis. So that is this report here. We can see right away there is dysbiosis present, and then we have the value to validate that. And then we can get into details actually with regards to the key findings for this patient's results. So we can see here, again, remember that dysbiosis index score of 4 represents dysbiosis. Then we have the report here. This row represents the key findings for this patient's results. The first column are the bacteria that have significantly deviated from normal biosis, contributing to that dysbiosis index score, and also represented in that web. And so here we have the detailed information that provides information for your patient. The second part of this row here, the second column, these are the rest of the results for the report. So these portions are independent. The first column is going to be associated with that dysbiosis index score, and then the second column is the rest of the results. There's quite a wealth of information here with regards to any potential parasites, any pathogens present, any cultured bacteria, any cultured yeast, if there's immunology markers, short-chain fatty acid imbalance, a lot of information here. So we can see for this result, with regards to the first column of key findings, there's quite a few bacteria that are elevated and decreased. And what we would really do is go through those and get more detail about the patient's presentation and see what would be advised based on this information. And then for the second part, we do see the patient does have 2 different parasites, white blood cells, abnormal consistency, and then there are 3 species of yeast. And then we do have elevated immune markers, lactoferrin, lysozyme, a lower pH, and occult blood. So this is all information to pay attention to here. So putting this all together can really provide the best information. Here we see the pages from the report, and these pages really are going to, this is the information listed line by line of the 45 analytes that are going to be considered to create that dysbiosis index score. This is represented in standard deviations from normal biosis. So the green area there is considered normal biotic within the reference range, the healthy population, and then we can actually see standard deviations above and below that. All right. And then again, this information is derived from N of over 1,000. So quite a validated approach here. And just as an example here in the third box there, we do see this patient has elevated proteobacteria, elevated Escherichia species, and that's really associated with inflammation, standard American diet. So that does go along with the dysbiosis index score of 4. And then the Akkermansia is low, and that is associated with mucosal barrier integrity. And so we do get a picture here of what is happening for this patient and how to best address that too. The wonderful thing about the GI360 is that it does include PCR and culture for pathogens and flora. Traditionally, culture provides a significant amount of data through the use of MALDI-TOF for flora and pathogens. So with that, with regards to that, the bacteria that are present within the patient's stool will be cultured, and then you have that information as well. And then with the PCR technology, you can detect pathogenic bacteria, parasites, and viruses. PCR technology is actually the only way to detect the viruses, so you need this methodology as well. GI360 includes all of that, and as you'll see, clinically, that does make sense. PCR is utilized for pathogens. These are FDA cleared probes, so that's great because you know what is being identified is what is being identified, and that helps to determine if your patient has a pathogen. You want to know that right away. There's a high degree of sensitivity and reproducibility here. As we know with DNA testing, it's excellent, provides wonderful information, although the limitation is that the probe can only identify what it's looking for. It's as if you're fishing for something and you have to have a specific bait on there. You are using that bait or that probe to identify that. It's a yes or no answer. And that's GI360 complements this with a broader scope by using culture and OMP, ovum parasitology via microscopy as well. Here we have an example of the gastrointestinal pathogens page, and this is where we are looking for the viruses, bacteria, and parasites. And here we have an example of the parasitology page via microscopy. And this is excellent information as well. There are wonderful parasitologists at Doctor's Data that really do take great care to identify these under the microscope. And it's quite incredible actually what they do and the experts that are involved in that. So here we see this patient had a blastocyst positive as well as a Dientamoeba fragilis. Okay, and then we have other markers to guide treatment as well. And those other markers here are shown that there's white blood cells, so there's some information and inflammation there. And then the consistency is loose and watery. So that could be due to the dysbiosis index score 4. That can be due to these blastocystis and the Dientamoeba. So we do want to address that. Microbiology is performed with the proteomic identification. This is still the gold standard for microbiology. So this is culturing for the bacteria and identifying them via the proteomic identification. And then this actually allows for once these organisms are isolated, then it allows for the standardized antimicrobial susceptibility testing. So you're provided with the susceptibilities for the cultured bacteria that has been directly derived from your patient's stool. It's not a wall chart. It's not like Doctor's Data is saying, and for any Citrobacter or Klebsiella found, you could use XYZ. It's actually unique and individualized. So that does provide the best information. Via using the culturomics, there's identification of unique organisms such as Archobacter. There is no probe set yet for Archobacter, and so using the culture, the microbiology is the only way to identify that, and unusual yeast. Currently, there's up to 180 species of yeast identified, of which 86 are Candida. So this is a wealth of information. The library keeps growing. So it's very interesting and neat to be able to do that. The MultiTOF library currently is identifying over 1,400 genera of bacteria and fungi. So here we see the culture page, and there's a wealth of information here. So the first part is the pathogenic bacteria, and as we can see, those are not cultured. Then we have the imbalanced bacteria. We do have a Klebsiella here, and then there are yeast. This page is going to look fairly different for each of your patients. You likely no two pages will look alike. It's very individual and dynamic. These fields are expandable. So for the pathogenic bacteria, there's actually another one, the Larybacter hongkongensis, which was recently discovered. If that's cultured, we will identify it. For the imbalanced bacteria, what the patient can really have anywhere from 0 to quite a few. We've seen maybe a dozen or so, and it is individualized for your patient. Any dysbiotic bacteria will be reported here as well, so you'll have that information. And then the yeast, any cultured yeast are reported here as well. Again, it's over 180 species, of which 86 are Candida, so that's quite a few, quite a lot of Candida actually. Here we see the direct susceptibility testing. This is excellent information here. So we have, recall, these 3 species of yeast were cultured, the Candida albicans, Luciniae, and the Rotula. So you have the susceptibility testing right here, and you can see this for natural agents, nystatin, and the azole antifungals. The way to read this, on the left-hand side is the low susceptibility, the yellow is the moderate susceptibility, and then the right-hand side, the green is the high. And you'd want to use from the high. And since you have this information, you can find the commonality across the 3 different species and then use the agents that are in common to work at those 3 different ones. Here we see the stool chemistries page. The stool chemistries page provides more information. The first part is going to tell us about digestion and absorption. So we have elastane, fat stain, carbs. Then we have the information about the inflammatory markers, lactoferrin and lysozyme. Recall that those are elevated. So this is something we want to follow up on with this patient, lactoferrin of 124. The secretory IgA is here within normal limits. And then we have those very important short chain fatty acids. It's very important to get this information about these microbial metabolites. And then we have other intestinal health markers. The pH, that is an excellent clue. We have a lower pH here. It's a loose, watery stool. There's a lot going on. The beta-glucuronidase, and then the occult blood is positive. So a lot of information here. Truly, the state-of-the-art testing is going to be combining these methodologies. We have the PCR analysis for the abundance and diversity of the key bacterial populations of the microbiome. And then we have the PCR detection for the pathogenic bacteria, viruses, and parasites, comprehensive parasitology by microscopy, and then the stool culture and MALDI-TOF for the identification and standardized susceptibility testing of cultured bacteria and yeast. Also a broad range of chemistry markers. Now we will get into some cases. As you'll see, the GI360 is excellent clinically. So the first case we're going to start with, this patient has previously overweight, actually struggled with lifelong depression and obesity. Within the last 3 months, the patient said that they switched to a less processed diet and lost 20 pounds. And they have a history of being treated with 3 rounds of antibiotics. This is a 42-year-old male. Here we see the patient's results. Recall, the web is the first thing we see. We can see this is deviated from normal biosis. We don't see that hexagonal shape. So we do see that this is deviated. And then we see the dysbiosis index score is a 5. Recall, 1 and 2 are healthy, normal biotic guts, and then 3, 4, and 5 are dysbiotic. Okay, and we can see it's skewed a little higher in those proteobacteria. Remember, those are a little inflammatory. Those are inflammatory. Here we have the key findings. So for this patient, we have some key findings. Remember, the first column there is going to be the information in detailed that has created that dysbiosis index score of 5. And then the second column there is going to be the rest of the report. So for this patient, we see an elevated diaster in Viscis and Megasphaera. Those species are associated with endodontic pathogens. In a healthy gut, they aren't present at these levels. The Parabacteroides species is very high. This is associated with a high-fat diet and obesity, and that's something the patient struggled with. Eubacterium serum is low, and that is associated with dysbiosis. The F. proteiniceae species, this is a very important species in the colon. It is associated with decreasing inflammation. It's associated with butyrate. It's a keystone species. So this being low is going to leave the patient at risk for inflammation. It's also low in patients diagnosed with major depressive disorder. So we have already 2 of the key findings associated with the patient's chief complaint. The next thing we see is the actinobacteria is low, and that is associated with a standard American diet. Again, all types low. Proteo are high. Those are associated with the standard American diet. The proteobacteria are inflammatory, and they really enjoy carbohydrates and fat. So this is going to be something to address for this patient. Okay. Allsipes endodonty, the Bacteroides fragilis is too high. The Escherichia species, again, another bacteria that's associated with a standard American diet and inflammation. So we can see that the patient does have bacteria that are associated with inflammation, a standard American diet, okay, and diagnosis of depression as well. The next thing we see here is the fat stain for the patient is high. And then we do see some short-chain fatty acid imbalances with regards to the propionate and the valerate, and then we have an elevated fecal secretory IgA. Here we take a look at one of the pages that is representing the Firmicutes line by line. We can see here that the patient does have deviations from normal biosis. Recall, the green area is going to be the normal biotic range, and then we have deviations from normal biosis. in the yellow and then the red. So the patient does have elevated diaster, and then they have that lower Ubacterium cerium and the F. protenitzii, and then the Lachnose over there as well. The Ruminococcus navis is a little bit higher, and that actually produces acetate, not butyrate. So another key here to the short chain fatty acid imbalance. Here we have the stool chemistries portion for this patient. The elastase is within normal limits. We do have a fat stain elevated, so recall the patient was kind of eating a high-fat diet with the standard American diet, and then we do have the secretory IgA is a little bit elevated. That could be due to food sensitivity, or it could be due to a gastrointestinal tract infection in the past 3 to 4 weeks. So you want to get a good history on that. So here's our second case. Now, this is a different case. This patient is a 32-year-old female, and she has been, her complaint is ongoing arthralgia, underactive thyroid. She's had alternating IBS symptoms, and they actually got much worse since visiting Hong Kong in 2019. And so that's really her main complaint here, is that her GI symptoms have gotten severe in the past few months. And she's taking medications because of a bike accident. Okay. Here we see her results. Again, we see that really this is not a normal biotic gut. We do see deviations from normal biosis with that abundance and diversity on that web. Then the dysbiosis index score of 5, so deviated from normal biosis. So for this patient's key findings here, we see that the patient is elevated in the proteobacteria, which is going to be inflammatory, lowering those healthy Clostridias. Okay, so some inflammation here and some bacteria that are low that we'd like to see elevated. Now, recall that we do have this other information here at the report, and it's great that we do, because we see that the patient has Salmonella detected, Giardia, Citrobacter, Klebsiella, Geotrichum, and then high lactoferrin and fecal secretory IgA. So this is an excellent case in that there's findings on both the dysbiosis index and the rest of the report. And so these all needs to be considered, okay? Here we see the patient's pathogen profile here. Recall, we're using the PCR technology to identify viruses, pathogenic bacteria, and parasites. So we do see that the patient did have a positive salmonella. This is highly sensitive and specific, so you do want to correlate this with the patient's presentations and symptoms. Recall the patient does have symptoms that potentially do correlate, as well as this Giardia. So this is very good that the doctor ran this test. And then we see the the microbiology page, the culture page for this patient. And we do see that the patient does have a cultured Citrobacter and a Klebsiella, Geotrichum. Recall the Salmonella here is not cultured, and so that just really goes to the strength of the test. And that is combining both the methodologies, the PCR and the microbiology in one test. And then here we see the susceptibilities for the Citrobacter and the Klebsiella for this patient. Like I said, you would want to choose in the green, that is the high susceptibility. And you want to choose something that addresses both of these bacteria. So something that's in common, such as grapefruit seasoning. Okay. Right, so thank you for your attention this evening. And if you have any questions. Okay. Thank you. So Joshua, I did send it over to you.
Excellent. Thank you, Dr. Malkowski. Okay. So I'd like to welcome Dr. Sodano and Dr. Quig into the discussion. Again, thank you for that insightful information, Dr. Malkowski. Any thoughts or things that you'd like to mention about the presentation that you'd like to highlight or accentuate from what Dr. Malkowski had shared?
I'd like to comment, if I can jump in here. In that last case, Doc, I noticed that the Klebsiella was high, and we know that's a potential autoimmune trigger. And I believe that patient was having joint pain, was she not? Yeah. Do you know if she picked up anything in Hong Kong, by the way? I've been to China a couple years ago, and I was real cautious about things as far as, diet, food. Yeah. What happened?
We don't know for certain, but potentially, yes. And we do see with the Klebsiella and the arthritises and the spondyloarthropathies, we do see that sometimes, yes.
Yes, there was a great tie in there with that. I enjoyed reading these cases, so thanks for bringing these up. A lot of good information. There was one analyte on there that I didn't see on many stool tests. I was trying to hunt that down. I was going to ask you about that one, and it was back the Charcot.
Oh, okay.
Yeah, I know, and here's I have a question, if you don't mind, on that one. Is I know that could create eosinophils going into the GI tract, but have you seen that, or even Dr. Quig with food allergies and sensitivities? Has that been jacked up? Because I haven't researched that one out a whole lot. If you can comment on that.
Yeah, that's a classic indicator of parasites. You see the charcoal-laden crystals. That's just an incredible common observation with parasites. So it really doesn't relate to food sensitivities or food allergies, but rather to parasites specifically.
How about gastrointestinal eosinophilic conditions? I know they're kind of rare, but I'm a geek, so
Yeah, it goes hand in hand. Absolutely.
Those will go up too. Yeah.
I mean, yeah, much more direct than trying to look for elevated eosinophils circulating, for example.
Yeah, I love seeing that on there. So whoever put it on, thank you. So it was good. Josh, were there any questions that anybody had?
I'm not seeing any come from the audience quite yet. So again, I'm going to encourage anyone that had questions or would like to discuss something about the test or what Dr. Malkowski had shared. I'll encourage you to chat in that question now, or if you want to, you can always raise your hand as well. And
well, I'd like to jump in here then if you don't have anything. I mean, the power of a test like this is absolutely incredible for you clinicians out there that are using this, because sometimes it'll go just PCR, sometimes it'll go just microscopy, and now we have this wonderful thing that I was telling Dr. Quig a while ago, this what I call the turbocharge, looked at all of the proteomics, essentially looking for the proteins of these bacteria, whatever they can find, yeast as well, using what's known as the matrix assisted, what is that? Help me out, laser desorption,
ionization, time of flight.
And time of flight. I mean, what a cool thing that can really pick up stuff. So when you do this test, you get a 3 for here, plus the culture and sensitivity. So this is a great test. So I guess I said it enough. But anyway, I like that whole idea. You're getting a broad spectrum. Years ago, we were just using microscopy. You're only looking at about 5% of the GI tract, and this thing keeps growing and growing, and you can get a real window. When you look at what Doc said, look at the patient history, combining the both of that, it's outstanding. And you're going to see a lot of similarities to their condition that they present in, like joint pain, knowing more of the bacteria. By the way, do you all report, Doc, on the what the bacteria, if it's high or low? Is there a report on the end of that? Or you have a guide that comes with this too, right? Yeah, the clinicians can use a guide, correct?
Yeah, there's two things really. With the report itself is a very thorough commentary for abnormal bacteria, yeast, parasites, etc. And then we also have a reference guide or manual that explains basically everything there, because you get into these 45 different PCR targets for the microbial diversity and abundance. And to be honest with you, some of those there's very little information on, but you go to the resource guide and you can find what is known about that specific strange bacteria that you never heard of before. And the reason why why it's there is because this is a clinically validated model, and the targets were selected to differentiate between dysbiosis and normal biosis. And so even though we don't at this point in time, and we're all very young with respect to really understanding the totality of the whole microbiome, some of these things we don't know a whole lot about, but we do know that they've been consistently shown to be, when elevated or low, to be associated with dysbiosis. So you can go as far as you want with these different PCR targets. You can get, what I say, sometimes lost in the weeds with them, but the take-home message is you have your dysbiosis index is telling you how far your patient's microbial community deviates from normal biosis. And some people will get in and dig further. And as you know, with a lot of these bacteria, there are not commercially available probiotics. And so you can understand their basic properties, like, they love soluble fiber, they love pectin, specific things. So when you read those commentaries, it can help you a lot.
Excellent.
Dr. Malkowski.
We're starting to get a few other questions in. If we can start to address that from the audience, and we can, get you some other questions in just a minute. But right now we've got a question. What was the name of the analyte that points to parasites? Was one question that has come in.
Charcot-Leyden crystals.
Okay, and again, everyone that is asking questions, we will have this recorded. It will be available for you to review. Let's see, next question. How does this test compare to the GI map, and what are the differences between this test and the GI map?
I'll take that one. The bottom line is, and it bothered me for a long time with our stool test, that we were stuck with microbiology, and then some labs came out and started doing just PCR and abandoned microbiology. And the reality is that there is no single perfect method to fully characterize all of the microbes. So it really requires complementary methods. As Dr. Juliet said, the PCR is very limited. It's basically, is it there? Whereas the culture, we can, look at over 1,400 different species in general. So a much broader net that we're casting there. So that's the biggest difference, is that there is no single perfect method. And you really need to look at end as far as the parasitology as well. How many probes for parasites are there with PCR? Not that many. There's an additional 30 that you can identify with O&P, with microscopy.
Excellent. Let's see, another question that's come in was, how did you treat the Giardia? I would imagine that was in reference to one of the case studies.
Yeah, that's going to be the standard of care treatment for Giardia. And I believe that is going to be metronidazole, hydroquinone. Yeah, that for the parasites, it's really standard of care. And then, so for some of them, like blastocystis is considered commensal within the human colon. So that's going to be up to the clinician. It depends on the other markers as well. So you want to look at all of the markers together and then make a decision. And then sometimes too, considering like fecal secretory IgA, if you have a parasite that you did want to treat, you'd want to see if that's elevated. So looking at everything together and then following standard of care would be the way to do it.
Okay, excellent. Let's see. Another question that's come in is, when we get the key findings results, will I get an explanation of it? For example, parabacterium related to a high-fat diet or proteobacterium related to high CHOs?
Yeah, absolutely. That's what I was talking about, the very thorough commentary. And that's one of the key things for so many clinicians is, okay, how non-pharmacologically can we deal with this imbalance in the bacteria? And many times it's just a matter of too much of one macronutrient and or not enough of the other, high fat, high protein, too high. And the dysbiosis index, when I first saw that study, the clinical study, where they found 16% of healthy people had significant dysbiosis, I thought, well, something's wrong with this test. But when you think about it, when people are on really bad diets, there is very likely a degree of dysbiosis associated with that diet. And as we started doing this and we're doing more consultations, it was bam, dysbiosis index scores of 4 and 5. Oh yeah, oh by the way, the patient's on a major ketogenic diet or an extremely restricted FODMAPs diet. So that information is provided and it correlates extremely well. So we're not just looking at IBS per se, you know, as per Rome criteria, or IBD. There are many different dysbioses, and so many are driven by the diet, a lack or an excess in the diet.
That's excellent. Thank you, Dr. Quig. And just to answer a couple other questions, so the reference guide is available through our website. We can provide that at your request. You can contact us at info@Evexia Diagnostics. We're always happy to get that to you as well. We've got a plethora of resources that we're continuing to make available to our clients. So that's always something we're going to make sure that you have support for using this clinical tool. Let's see, another question that's come up is, how many bacterial targets, fungal yeast targets, and viral targets does the GI360 include?
Well, in terms of specific targets, you'd be speaking to molecular PCR. So there's what, 45 in the diversity and abundance, and then there's what, another 20 or so in the pathogens, GI pathogens. So there's over 65 very specific targets. And then with the culture and proteomic identification, we're talking over potentially 1,400 additional. So not limited to, okay, do you have this target? Do you have that target? No, we have specific PCR-based targets, but an additional, you know, in excess, and that number of 1,400 just, it grows, you know, by month as you discover a new protein pattern associated with a particular bacteria. It gets added to the library. So quite a big number.
And so what, if I'm understanding what you're conveying, Dr. Quig, is that the test is only going to continue to get better over time?
Yes, and even with the dysbiosis index, the microbiota diversity and abundance, I mean, there's currently data from over 5,000 patients in those 20 peer-reviewed papers, but the papers continue to come out. People are just using this tool and apply it to very specific diseases. It's definitely a growing piece of work.
Yeah.
Excellent. Did you have something else to piggyback on there, Dr. Malkowski?
No, I was just, it is growing, and it's you know, it's quite fascinating to see and to learn about. It's quite fascinating, and I'm excited to see where it will go, because just the little bit that we have seen has really panned out. So it'll be great to see what information we can have in the future.
Excellent. Let's see, another question that's come up is, what is a high-level therapeutic plan for each of the cases that you presented in your professional opinion?
Okay, so for those cases, I think, let me just pull up again the results. Yeah, so the first case was the patient, their chief complaint was the obesity and depression. And so really we'd want to weave a thread through the key findings that are associated with that dysbiosis index, because that was the key to that case. There was a fat stain positive, and then there was some short chain fatty acid imbalance and fecal secretory IgA. So you'd want to see about the fecal secretory IgA. Did the patient have a gastrointestinal tract infection in the past 4 to 6 weeks? Then that would explain that. If not, perhaps there's a food sensitivity. And then the fat stain is potentially related to the diet, but you'd want to find out as well. And then the short chain fatty acid imbalance, I mean, we did see that reflected in the key findings. So for that patient, the key findings were pretty consistent with regards to a standard American diet and inflammation. So you'd want to address that, and really you can get fairly specific with that. Like Dr. Quig had said, you can find out with those specific bacteria what they enjoy. In that case, the bacteria that were too high and associated with the standard American diet really liked high fat and carbohydrates. So you'd want to go through and discuss that with the patient, do a diet diary, really tweak that. And then the bacteria that were low, really like the F. protenitzii, that keystone key butyrate producer, anti-inflammatory bacteria, that really healthy one for the colon, that species likes inulin, and so you'd want to add there. So you want to add where the patient is deficient, and then you'd want to decrease where the patient is in excess and contributing to those inflammatory bacteria. So that would be for that case. Is there anybody would want to add anything else to that, or any other comments? Okay. And then, so then for the second case, with the pathogens that were found on the PCR, that's really going to be the crux of that case before the other. The dysbiosis index score is 5. So depending on how you treat your patient compliance, you might want to go into both at the same time, but really you need to address that Giardia, Salmonella, and then the dysbiotic Citro and Klebsiella as well. So for here, we see the fecal secretory IgA was elevated. Recall that that is the immune response. That is potentially appropriate. So this would be, you wouldn't necessarily have to address that. It does appear that the body is mounting an immune response. So that's promising. But for the Citros and the Klebsiella, you could use the antimicrobials, the pharmaceuticals, or the non-pharmaceuticals. That would be your choice. And then also for the yeast, if you wanted to treat that. So it depends really where that patient is at and what you want to do. But you definitely want to address those pathogens immediately and then go from there.
Yeah, that's a classic case of, the chicken or the egg. So a very active question that we're dealing with is, what type of dysbiotic, how can we characterize dysbiosis, say associated with a particular parasite? But when I think about that, I say in a case like this, yes, there were definitely dysbiotic bacteria, yeast, and parasites, but was it the dysbiosis of 5, you don't want to be in that club, that set this patient up for these, this train wreck waiting to happen, or is it a result of that? And so as Dr. Malkowski said, first and foremost is treat the pathogens, and then obviously try to restore or rebuild and get that back to a normal, healthy, defensive microbial community. So, I mean, that's just a burning question that I have is, and I think in many cases, when we trace it back to a really bad diet, it is the dysbiosis that sets up for the pathogenic bacteria in many cases.
Excellent. Let's see, another question that's come in is, one of the attendees was looking at the test. They didn't see H. pylori. Is it tested in the GI360? And I can give a quick answer, but I'd like maybe for Dr. Malkowski to give, or even Dr. Quig to give a little further clinical insight. But I know that H. pylori is available as an add-on to the test, if that's correct. But can you maybe explain why it's not just automatically included in the profile, why it's available as an add-on?
Yeah, I'll take first stab at that. Feedback from our clients was not everybody wants H. pylori. You know, at some point worldwide, that is 50% of people are going to actually acquire H. pylori infection. 85% of those people are asymptomatic. So many clients, unless the patient is symptomatic in that direction, don't want the H. pylori, but for those that do want it, it's as an add-on at a very reasonable price. So just, you know, meeting what people want. With respect to H. pylori, you know, there's a lot of fascinating research about it, and the virulence factors and all that, which have to be taken into context as any genetics. You have to look at the rest of the genetics of the patient, as well as the environmental factors. But one of the concerns is when people see, oh, there's H. pylori, oh, well, it's at a relatively low level, the quote cure or treatment can be worse than the infection in many cases. And again, with 85% of people asymptomatic, I personally don't want to be contributing to people excessively overtreating H. pylori. So really leaving that to the clinicians.
Excellent. Is there anything that you'd like to add, Dr. Malkowski or Dr. Sodano?
Well, yeah, here comes the fly in the ointment here that most people may or may not be aware of. So here it comes. H. pylori may offer some protection for the Dr. Quig's laughing about that. You agree with that?
Yes.
Have you seen the research on that?
Yes.
Yes. So it's like, you know, when I read that many years ago, I'm like, because I was like, get it out, get it out, get it out. I'm thinking, wait a minute, you know, let's hold off just a moment, because it may offer some protection at some levels. I mean, if you have, you know, an ulcer and things like that and you're symptomatic, fine. But the question becomes, do we want to eradicate it, offering some protection? So it may turn out that, you know, I don't know if Doc wants to talk about that, but it was like an interesting, so in a way, I'm kind of glad it's not on there, you know, so, and, you know, use it as an add-on. So anyway, that's just my 2 cents, the fly in the ointment. So with that one, everybody shaking, you're all shaking your head. So.
Absolutely, I would agree. 100%.
Right, I'm not getting yelled at through the computer here because everybody's like, what? But anyway.
All right, there's another question that came in. Does the test clearly distinguish gut permeability issues from nutrition, parasite, or bacteria issues, and how is it indicated in the charts?
I'll deal with that one. There is a tremendous misconception that the vast majority of patients have increased paracellular transport or increased intestinal permeability or quote leaky gut. When we actually use the serum zonulin or the old classic gold standard in allopathic medicine, the lactulose mannitose test, we find similar positivities, that is 15% of submitted samples. Now remember, these are patients in most cases where they have some sort of reason to have their gastrointestinal health assessed. Only 15% of samples that we receive by zonulin, serum zonulin, or lactulose mannitol actually have, you could make a diagnosis of increased intestinal permeability. I've seen cases where there was so much going on, like in that last case, where you'd think you'd be inclined to say there's got to be increased permeability. But then when you look at the serum zonulin, not fecal zonulin, but serum zonulin, It's not. And so it's sort of like the old myth that, you know, everybody has yeast overgrowth when the book came out in the 80s. Not everybody has yeast overgrowth. Not everybody has intestinal permeability. You can definitely infer by a grossly dysbiotic gut that there's high probability of mucosal barrier dysfunction, but whether or not that's real, I guess the good news is if you're from that school of thought, the treatments for intestinal permeability are rather benign, and unlike with H. pylori, you're not going to do more harm than good.
Yeah,
Well
I would.
said. Very well said.
Dr. Malkowski, did you want to?
Yeah, no, I would agree. It's you know not a direct test for that. Like Dr. Quig had mentioned, the serum zonulin and the lactulose mannitol. There are some bacteria though that do give clues, such as the Akkermansia eosinophilia, and there are bacteria which do contribute to the mucosal barrier, and that is potentially a predisposing factor to increase intestinal permeability, decreasing mucosal barrier. Again, not a direct test, but you can garner some information potentially and maybe do a further follow-up test. So, yep.
Excellent. Well, we are getting close to time, but before we conclude, there's a few things that I'd like to do. First off, I want to give everyone another opportunity to anything else that they'd like to share, especially to you, Dr. Sodano. I know that you engage with our clients every day, multiple times. Is there something else that you'd like to highlight or let them know about in how this test can be a huge benefit to their practice and their patients?
Well, like I said earlier, looking at the PCR and then culture sensitivity, microscopy, it's a very, very good test. I was so glad to see this out there, and you're going to get like a lot of really good information. I was glad to see that lactoferrin was back in, because that lactoferrin seems to have gotten dropped out, and lysozyme. So I was really glad to see that back in as the stool markers, because they could be helpful to differentiate between irritable bowel syndrome and inflammatory bowel. So there's a lot of good information on here, and I'm looking forward to ordering this and helping our clinicians, go through the paces here, because if they're not sure, they will call me and we'll set up appointments, or I'll do it online for Evexia. So really just, please avail yourself of this wonderful information.
Thank you, Dr. Sodano. Dr. Malkowski, anything else? Any final words for our attendees?
Nothing at this time, but yeah, I appreciate the time that everyone has given to this test, and looking forward to hopefully great clinical results. So thank you.
Thank you. And Dr. Quig?
Just one closing comment was, of the functional medicine labs, the complementary labs, we were the last people to come to the table with the molecular, the PCR, and that's not because we didn't believe in it. It was because we weren't satisfied with what was available until we came across the FDA cleared and the CE cleared, the European Union cleared PCR platforms. It was hard, everybody was running past and everybody was running the PCR, but we held out and waited, and now we have extremely highly standardized PCR to offer that you can really count on.
Yeah, I saw the CE on there. I probably should have mentioned that. That's a big deal. So quality assurance, that's a big deal.
Yeah, absolutely, absolutely. Well, thank you again. And there was other question that came in. How much does the GI360 cost? And I'll just field that real briefly. Cost for that is $379, and because that H. pylori question came up, that add-on is $39 when you add it on to the GI360. Again, thank you so much for the clinical insights that you shared, Dr. Malkowski, Dr. Quig, Dr. Sodano. For the attendees, please know that if we were unable to address your questions, or you have questions that come up after the fact, please reach out. We'll do our best to make sure that your questions are answered. Before we conclude, I want to just review briefly, now that you know about how terrific this test is, the benefits and value that it provides, want to just take a minute to walk you through how to order the test through our test menu. So I'm just going to quickly share my screen. All right. All right, can you see my screen?
We can see it.
All right, fantastic. All right, so pretty simple process. What you're going to do is first just log into your Evexia account and click on the test menu link. Next, you would use the test menu to locate the GI360 test either through the icon in the featured section or through the doctor's data logo found under the laboratory partners section. Next, you would review the test and click the Order Test Kit button in the top right-hand corner. And finally, you would confirm your account information and desired quantity of the test. Then click the Place Order button to complete the process. Now, be aware that we can now also drop ship a kit directly to your patient. Now, to do this, you simply would replace your clinic name and address with the patient's details. The only thing that you need to keep in mind is please note that shipping charges will apply, but we are able to do that now. And of course, we are happy to assist you with any issues or questions that you may have. We can be reached during our extended business hours between 8 a.m. and 8 p.m. Eastern Time at 888-852-2723, Monday through Friday. And you can contact us anytime via email at info@evexiadiagnostics.com. Thank you again, everyone, for attending this webinar event. From all of us at Evexia Diagnostics, we wish you all the best on your pathway to wellness. Take care, everyone.